They learned how to cry like humans do. I'm breathing in, I'm breathing.
Hi, welcome to the Tommy Rocket Show. This is our 197th show. We're here today with Peter Phipps. He's on the faculty at URI. He teaches journalism. And we're also here with Dr. Kirsten Langdon. She is the director of the Lifespan Recovery Center. Welcome, doctor.
Thank you.
Welcome. Thank you so much for coming. Peter, isn't this exciting and such a hot topic?
It's good, yeah. Well, it is a sad topic, actually. Opioid overdoses are in the news. They're not just a problem, they're an epidemic, right? Officially in all ways. And so what does that mean? What other epidemics have there been? What's the scale of the death and the problem?
Yeah, we're definitely seeing that we're impacted by the opiate epidemic far more than any other epidemic that we've seen recently. So certainly across the entire nation, this is something that's affected everyone. I think a recent report said that close to 130 people die every day from an opioid overdose. But in the state of Rhode Island, we've been affected really badly as well. And so I think there's been reports that say that we're in the top 10 states that have been affected by this epidemic with the number of deaths that have occurred.
I've seen there are a lot of news stories, and many of them seem to be concentrating on fentanyl. And so give us a brief...
what is it?
Yeah.
So fentanyl is an illicitly manufactured synthetic opioid. What that means is it's not something that's regulated by the FDA. It's not a medication. It's sort of like heroin, but it's illicitly manufactured and is extremely potent. So that's what's made it so dangerous, is that we don't quite know how potent it is. There's different strains, there's different variations.
There's no control.
Exactly. And so oftentimes fentanyl is mixed into other substances without the user's knowledge. And so if someone goes and uses a drug in the same quantity that they've always used it in and sort of had a good effect from it, if fentanyl is mixed in and they're not aware of it and it's so much more potent, then that's what's contributed to such a high rate of the overdoses.
So what would be an example of that? Someone is addicted to what they, for some reason, they can't get it, and they go out on the street and they get fentanyl, and it's represented as what? An opioid or OxyContin or heroin, or how does it? I would think the word fentanyl has such a negative connotation. It's a synonym for death almost. You would think that people would say, oh, hey, I don't want...
Right, so a lot of people don't actively go out and search for fentanyl. So exactly right. So people become addicted to prescription pain medication, or they become addicted to heroin. And so they might go out searching for those substances and instead be given fentanyl, but without their knowledge. And so if someone's using heroin and they think it's heroin, it's not until after the fact that they learn that there was fentanyl in it.
Does it look like heroin?
Yes, yep. And the same is true for even cocaine. So we now know that there's circumstances where a cocaine user will use a batch of cocaine and there's fentanyl even mixed in with that. And so overdose can occur in that state too.
And what kills you? What is it that you stop breathing? You stop... What happens?
Yep. So opioids affect different parts of the brain. That's what gives you the euphoric effect from them. But opioids also can affect the part of the brain that regulates your breathing. And so at really high doses, or when it's mixed in with other substances like alcohol or medications like a benzodiazepine, that's things like Xanax, Valium, Klonopin, it slows your breathing down to the point where sometimes people stop breathing and they'll, can die from that.
And that probably slows your heart down too.
Exactly, yep.
So I've seen this map, you obviously know what I'm talking about, where you look at where the deaths are, and it's like a corridor of some dark color, of a death zone, and it goes from Ohio and Kentucky, and it comes through the middle of the country, and it ends up in Maine, and it sweeps through Rhode Island. So
what is that representative of?
And why is Rhode Island in that death zone? So,
There's probably a variety of factors going back to, really where this epidemic began is with the prescribing of prescription opioids. And so back in the 1990s, doctors were prescribing opioids in a much more kind of frequent in loose manner. We didn't sort of know how addictive they were. And so over time, with these kind of prescribing practices, people became addicted to the pain medications. And then as we sort of learned that they were addictive, there became greater regulation around the prescribing, and they became less available, which is why then people turned to heroin as a way to sort of substitute the addiction, right? So opioids became, the pain medications became less available sort of in the illegal market. And so then people turned to heroin because it's A, more affordable, and B, more acceptable or easier to access.
So would there be less deaths if there was just free access to opioids?
I'm not sure that that would necessarily help, but I think that it's educating people and kind of going back to the prevention standpoint, right? So now I think we're in a position where we should be far more cautious about starting someone on an opioid medication and really looking at sort of the risk and the benefits. And instead of maintaining someone on opioids in the long term, say for a chronic pain condition, really limiting it to instances where there's short-term acute pain. And not making it sort of an ongoing kind of prescription.
Right.
So was part of the problem, by the time the doctors started prescribing less, a lot of people were already addicted?
Exactly.
So how do you, Kirsten Langdon, find yourself on the front row, on the front lines of this horrific epidemic?
Mm-hmm. Well, as a clinical psychologist, I've been someone that's always been interested in both understanding substance use disorders through both clinical practice and also research, and also providing treatment for this population. And so that's something that I've been studying throughout my graduate training and postgraduate training. And since I've been in the lifespan system, it's been a population that I've been especially interested in providing treatment for.
So you study tobacco addiction, I read.
Mm-hmm.
What are the similarities?
So there's a lot of similarities across addiction in general. So we know that for a lot of people, addiction starts because they're suffering from anxiety, depression, or other sort of negative emotional states. And a substance is one really good, easy, quick fix to eliminating those states and making you feel better. The problem is that over time, as someone is using more and more of these substances, there's a lot of negative effects that happen as a result. So they have relational problems, potentially legal problems, financial problems. So now not only do they have sort of that baseline level of anxiety or depression, but now they have this additional stress level on top of it as a result of their continued drug use.
Excuse me, may I ask you, does the initiator of the problem come from genetics? Is it like the type of personality they're born with, or is it conditioning, or, is it a bit of both, or?
Yeah, we usually look at what we call kind of a biopsychosocial model, meaning that there's likely a genetic component, so there's some biological factors that make someone more vulnerable to experiencing addiction, but then there's also kind of social or psychological factors, so maybe someone in their household modeled for them that substance use is a good coping strategy, or over time they sort of were exposed to different high-risk situations and learned that this is sort of a good way to cope with these negative emotional states. So it's likely a combination of things that explains it.
How many people would you say in Rhode Island or have an addiction or a substance abuse problem involving opioids? Is it thousands? Is it tens of thousands? What?
I'm not totally sure of the number, but I think that there's probably far more people than we even know about. So we're able to look at sort of who's accessing treatment, who has sort of had encounters with emergency departments or other ways, but I think unfortunately there's probably a large subset of the population that people aren't screening for, or we're not aware that they have an addiction. And that could be an addiction to anything, right? So alcohol, cocaine, marijuana, opiates. And so addiction is definitely something that people struggle with in a large way.
But the death number is like 300 a year or something in Rhode Island, right? Isn't that what it is?
Yes, yeah. just over 300.
So 300 a year, and if 1 in 10, it would be 3,000, but it can't be that high, right? Not 1 in 10 people with an addiction or a substance abuse problem die every year. It's not that dangerous, is it?
I don't know the exact numbers, but I mean, it is quite dangerous. And so there's kind of two things that we're looking at. There's the number of overdoses. So someone can have multiple overdoses in their lifetime. So sometimes in our treatment center, we might even see individuals who have had 3 overdoses in 1 month period of time. And then there's the people that have had fatal overdoses. That could be the first time overdose for them, or that could be multiple overdoses.
So where does the center come into all this? Where does the Lifespan Recovery Center fit in to the problem in Rhode Island?
So we're really focused on providing easy access to treatment for this population and really trying to provide comprehensive services to make sure that we are addressing all of the social and the clinical needs through medication and therapy and other psychosocial supports, but really providing a place for people to get treatment when they're ready to start working on recovery.
And how many clients or patients do you see a year, a month, or how extensive is your network of care?
So right now our center sees probably just under 300 patients each month. And each week we're enrolling new patients. So one of the things that we're really closely focused on is trying to get people into care as quick as possible. So we have intakes every day for new patients that are coming into care.
May I ask you, I'm sorry.
Go ahead.
How long has the center been in existence?
We opened in June of 2017, so just over a year.
Oh, it's new.
Coming into 2 years.
And do you actively reach out to the populace of Rhode Island to let them know you're there? How do people find out?
So we do work with all different types of providers in the state to kind of let them know that our services exist and how, if they have a patient that they identify, how to get them into treatment. We also try to work with different community organizations, so Anchor Recovery, which is a peer recovery network. We have one of the peer recovery coaches at our center, so we work closely with them so that when they identify someone with a substance use disorder, to get them into treatment. So it's just really trying to get the word out that this treatment exists and that we're here to accept patients when they're ready to start treatment.
And you get a lot of people from the ER?
We do.
Police in the ER bring you a lot of patients, referrals?
Yeah, so we've tried to work really closely with the emergency department, so whenever they identify a patient who's either come in for an overdose or a related issue, like they have an infection or they're in withdrawal, that the ED can call us immediately and send the patient over on that same day so that we can get them into treatment right away.
So our next segment is going to be exactly the sort of the nitty-gritty of, well, actually some of the drug therapy that you're involved in at the center.
And we'll address that as soon as we come back with the second segment of the Tommy Rocket Show, so stay tuned for these public service announcements.
You hear people say it all the time. Someone else will do it. Someone else will donate blood. Because someone needs blood every 2 seconds. I'm happy to do it. It's just that it's a lot for one person to take on. Good night.
Good night.
Good night.
People go, fish don't have feelings. I'll go, have you ever seen a fish gasping for breath when you take it out of the water? They're saying, thanks a lot for killing me. It feels great, you know? No, it hurts.
Welcome back to the second segment of the Tommy Rocket Show. As you know, we're here with Dr. Kirsten Langdon and Peter Phipps. Peter, where are we in this?
We were talking about the Lifespan Recovery Center. And so the obvious idea is, so what are you up to? What's your treatment idea?
Yeah.
What's your mission statement?
Your model. What's the model for
there
the
you are,
center?
Tommy.
The model.
Yes.
All right.
So we really strive to provide comprehensive and multidisciplinary services for individuals with substance use disorders, but we also specialize in opiate use disorder. So when we say multidisciplinary, it's really bringing to the table a team of people from different disciplines that can help support the patient in their kind of quest towards recovery. So that includes physicians who prescribe the medications. We have therapists who provide either individual or group therapy. We have people who provide case management. So we know that for individuals with substance use disorders, there's often a lot of barriers to being in care. So difficulties with transportation or housing or health insurance. And so case management is a way to link people up to those resources that can help overcome some of those barriers.
Right at the center.
Right at the center,
And
yes.
what's the size of your staff? I mean, how many people work with?
We probably have about 10 providers in general between all of the staff that we have there.
And you direct the them and manage them and run the office, right?
Yeah, so I provide sort of general administrative oversight to the center, and I also, as a clinical psychologist, do see patients individually for counseling as well.
So, we all know there are places where you can go in and get Suboxone in neighborhoods around Rhode Island. How many? There must be 30, 20, there are a lot of places. You do more than that, I assume, than just give out, but the medication's important. Why don't you explain the relationship?
Sure. So when we talk about medication-assisted treatment, there's really 3 FDA approved medications right now. So that is methadone, buprenorphine, which many people will know as Suboxone.
Which we can't pronounce here.
Buprenorphine.
Buprenorphine, yes.
Buprenorphine.
I can't pronounce it.
That's
Also
all right.
known as Suboxone.
Yeah.
And then we also have Naltrexone. And all of those medications work in a slightly different way, but the goal is really to help stabilize the person as they start in recovery. So, we always give patients the option and help them sort of decide which medication is best for them. Sometimes patients may decide not to do a medication, but we really strongly encourage the use of medication because the evidence really supports the use of this type of medication in the treatment of opiate use disorder. So for individuals who may not use a medication, there's a higher risk of relapse. So we really look at medication as being one important component of a larger treatment plan.
There's an idea. Well, what do you mean? You give them a drug to come off a drug? How does that make sense? You must get a lot of that, right?
To wean them.
Why can't you just stop?
So I think unfortunately this is still one of the misnomers that's out there and one of the things that contributes to the stigma of using medication-assisted treatment. So a lot of patients will come in and say, well, I don't want to replace one drug with another, or they have family members and friends that are saying, why can't you just stop? You don't need to be on something else.
Right.
But the reality is that the medication is really important and can help the person kind of make those changes to brain chemistry that can help them make the changes that they need to in their life to support their recovery.
Instead of just crashing.
Right. So the medications really help in terms of alleviating withdrawal symptoms and also sort of helping to reduce urges and cravings. So as the medications are on board, it kind of gives the person that stability so that they can start working on making behavioral changes, lifestyle changes, cognitive changes around kind of their thought process of drug use. So it really is an important part of the treatment plan.
We'll get to some case studies later, but how long might someone be on the Suboxone or methadone or something? How long can that be a lifetime thing for some people?
So there's no sort of magic number of how long someone needs to be on to get benefit from it. It is approved as a maintenance medication, which means that someone could be on it sort of indefinitely as long as they found it to be helpful and there weren't any negative side effects or harms coming of it. So, we really try to work closely with patients to help them identify what their goals are for treatment and then support them through that process.
And what have you noticed about the way people, and what have families or friends, how do people act when they're on methadone or Suboxone, as opposed to, let's say, on a full-in opioid? How are people's day-to-day, how do they see the world? How do they feel? How do they think? What do they like?
Well, really the goal of these medications is to adjust the dose so that they don't have urges and cravings, they don't have withdrawal symptoms, but they also don't get a high from it. So that's really the important difference, is it really just helps people feel normal. And that's actually what a lot of patients say to me is like, gosh, for the first time in getting on this medication, I feel like myself again. I feel normal. I feel like I can interact in the world and not be nodding out all the time. And so it's really meant to sort of give them their sort of baseline stability.
But can those drugs also be abused?
Sure, yes, and unfortunately we do have diversion happening with, especially with buprenorphine, but people can also use it as a way to sort of start their treatment on their own. So kind of a new thing that we're seeing now is that before people enter kind of formal treatment with us to start Suboxone, they've actually kind of started Suboxone on their own, sort of just off of the street, and it's actually been quite helpful for them.
Can they buy it on the street?
Yes, yeah.
How does it get to the street?
Probably in the same way that prescription opiates get to the street, right? That someone's prescribed it, maybe they don't need as much as they're getting, and so, or they stop taking their own prescription and
they can fill it and they
can
sell it.
But I think in some ways it sort of helped people kind of start their own recovery before they've started a treatment
And you say
program.
that's something you've noticed of late? Is it because people are admitting it, or do you think it's just starting, something that's new?
You know, I'm not quite sure, but I think that, you know, as people are sort of seeing this epidemic happening around them, I think there's a lot of people that really want to stop using illicit opiates. And, you know, their first sort of encounter with Suboxone may be in sort of like the community setting on the streets, and they want to try it just as a way to sort of, you know, get out of that cycle that they're in. And so maybe before being in a formal treatment program, they sort of try Suboxone on their own to see if it's helpful, to see if it works, and to try to kind of take that first step towards getting into recovery.
That's very interesting.
May I ask you, when they take these drugs, do they have to take them every day?
Yes, so both the Suboxone as well as the methadone are medications that are taken orally every day. The Naltrexone, or the injectable Naltrexone, which is the one that's FDA approved for opiate use disorder, is a monthly injection. So someone comes and has a shot once a month, and that actually doesn't help with withdrawal symptoms, but it blocks the effects of an opiate. So in that month period of time that someone has had the injection, if they were to take an opiate on top of it, they would get no euphoric effect from it. So that medication is really helpful from a relapse prevention standpoint.
Now, this is a little off the mark, but a lot of people have heard of what Narcan. And what is Narcan saves lives. Have you run into addicts who carry their own Narcan alive to save themselves, or is that impossible?
So if you have overdose, you would not be able to
Because
administer
you would be out of it.
Exactly,
Right, okay.
so you're unconscious.
Right.
But there's really been this huge encouragement by the state and the communities to make Narcan as accessible as possible, because there are moments where you can interject and really save someone's lives. So it really is just an opportunity to have this medication available. So we encourage patients to always have a kit at home. So their partner, their mother, their loved one, if they were to see them in a state of an overdose, they could administer it. And that has really profound effects before you call EMS and they come.
So what you're basically, when you say that, you're realizing that your help may not be helping some people, and they may succumb to an urge, or and they could get themselves in trouble, and they probably know they can get themselves in trouble. So you put that on the table, and then you urge them to have Narcan in the house.
So I think from two perspectives. One, I mean, we know that substance use is a relapsing condition, right? It's something that we always have to be thinking about and working on, and encouraging people to be taking steps to keep themselves safe over time. So I think having Narcan available from that perspective is helpful. But also, you know, for some people, they're in sort of a network of knowing people that have a substance use disorder or an opiate use disorder. So even if they're working on
yes.
recovery, they may have another family member or friend who's still struggling with addiction, and so if they have a kit available, it just increases the likelihood that they'll be able to use it at a time when they really need to.
And do you ask questions when they say, I've used my Narcan kit and I need another one? I mean, how free are you? Are they for sale? Do you register the sale? How regulated is that?
So we can put in a prescription for it, but there's also a lot of community-based organizations that can provide these things for free as well. And so, you know, standardly at the Lifespan Recovery Center, we really try to make sure that all of our patients have access to a Narcan kit through a prescription or otherwise. I know in the emergency departments, that's one thing that they've been doing as well, is if someone comes in for an overdose, they try to make sure that they go home with a Narcan kit and know how to use it and know the signs and the symptoms of overdose. Make sure that they don't use in isolation, so it's always better to have someone with you if you're using.
Is it like an EpiPen, like if you have an allergy attack and you're closing up? Is it like that?
So there are injectable ones, but most frequently it's a nasal spray. So it's just about kind of squirting.
Oh, so it's
into
very
the nose.
easy. There's no issue of I'm going to stab somebody with a needle kind of a thing.
Right. And honestly, there's no downfall or harm of administering it to someone who may not be in an opiate overdose. So there won't be any negative consequences if you give it and it's not an opiate overdose.
So one thing, I saw a national statistic. There's 1.7 million Americans or someone who are have an opioid dependence or abuse issue. That number doesn't seem large enough for the amount of deaths, but is that the number that you use or you've heard?
Yeah, I mean, again, I think this is of the people that we've screened and that we know about. That number could be even underreported, but it is absolutely something that people struggle with. It's pervasive across the entire country. I think the other thing that's important to keep in mind is that opioid addiction doesn't just focus on one particular group. It really affects every demographic, every age
broad
group.
demographic.
Yes, yep. It's not discretionary. You know, anyone can sort of fall into the cycle of opioid addiction.
So like many people would assume heroin is a product of poverty, but that's not necessarily true in this case, right?
No, not at all. Nope, we really see that it really hits sort of every major group, unlike we've seen with other substance use disorders.
In our next segment,
Which is coming up.
which we're going to talk about family and friends and danger signs, and because for everyone who dies, I'm sure they had people who might have said, "Oh, I knew there was a problem there or something, and they didn't do anything." And, so we'll get to
And
that.
we'll discuss that when we come back for the third segment of the Tommy Rocket Show, so stay tuned.
Hi, this is Bill Maher, Politically Incorrect. I can find humor in almost anything, but one thing I never laugh about is cruelty to animals. If you don't get the joke either, write People for the Ethical Treatment of Animals, 501 Front Street, Norfolk, Virginia, 23510.
Hello, I'm James Cromwell. In recent years, the emergence of factory farms like this one has meant bad news for pigs. The largest U.S. slaughterhouses kill one pig every 3 seconds. Such an accelerated speed means that millions of animals have their throats slit or are dropped into scalding tanks while they are still conscious. Pigs are sensitive, intelligent animals. Please do your part. Stop eating pigs. Thank you.
Hi, and welcome back to the third segment of the Tommy Rocket Show. Peter, Dr. Langdon, what were we talking about?
Well, we were sort of on the subject of demographics, and from what you know, tell us about the range and the types of people that come through your center and seek help.
The demographic.
Yeah, so as I mentioned earlier, I think one of the unique things about opiate use disorder compared to maybe other substance use disorders is that there's really no one particular demographic that's at higher risk for experiencing this. It's, you know, men and women are equally affected, different ethnic groups and racial groups are equally affected, and also in terms of age range. So I can tell you that at our center, we only treat adults, but in our center we have patients that range from anywhere from 18 all the way up to 78 years old. And so no one is really safe from this addiction. It can really affect anyone.
Family income is a factor at all?
Not necessarily, and in fact, you know, it has been relatively prevalent in middle and upper classes as well.
And that would be their access to painkillers, I suppose. That they probably don't have street access. The same, maybe the place that the addiction begins might be different. Is that a possibility?
It's a possibility, but I think sort of it also underscores sort of the grips that this addiction has. And so, you know, just to give you an example, I recently worked with a woman who was a mom who also had a pretty high-powered job, and she got, you know, hooked on the pain pills, and she had a dealer for heroin, and she would, you know, call the dealer and meet them in all different places in the middle of the day.
Really?
And so it really just kind of shows you this is not someone that you would typically think is someone who might struggle from an opiate use disorder or a substance use disorder, but she did, and it very much affected her life.
And how did she end up in your office?
So she was someone who actually presented to the emergency department, and she was in, I think at one point in time, she just said, I've had enough of this, and she was in withdrawal, and she didn't want to go back to her dealer, and so she ended up presenting at the emergency department and asking for help.
Presented, means, what is presented?
Showed
means?
up.
Yes, just
Showed
like
up. She showed up in trouble.
Yep, and said, you know, I'm in really severe withdrawal symptoms. I don't want to go back to using. I'm looking for treatment. I don't know how to get into treatment. And then they referred her over to us.
Can you say what community this person lives in?
I actually don't know off the top of my head,
okay.
but
Safe, then it's safe.
yeah.
So let's take that case, that woman. She was surrounded by colleagues, family, and friends. Well, couldn't they have seen the danger signs? Let's just take that woman. The circle, she must have had a very big circle of people who are in contact with her on a daily basis. So what might those family and friends have seen, or what could they look for in a similar case?
And let me just say too, before I get to that, that I think one of the things that's so difficult about a substance use disorder is there's so much shame and guilt tied to it, right? So people will go to such extreme lengths to keep this hidden from the people in their lives. So with this particular woman, you know, I remember talking with her once her husband found out about it, and you know, she told him, I want to get into treatment, this is what I'm struggling with. He knew something was off, he knew something was wrong, but never in his wildest dreams did he imagine that it was heroin use. I mean, he was blown away. So he could tell that there was something that was not quite right, and she was struggling with something, but substance use or drug use was not the thing that kind of came to his mind. And she did a really good job of hiding that, you know, going to these extreme steps to make sure that he
Like
never
what?
knew.
For example, what games or charades or acts would she go through? I mean,
So things like, you know, keeping her cell phone out of his view so that he didn't know, you know, who was texting her, making sure that she coordinated, meeting up with her dealer at times when he was at work, being very careful about how she used, when she used, so that there was no paraphernalia kind of left around, and trying to sort of always be on when, you know, people around him might notice something. But
Making sure the kids weren't around.
right. So just making sure that the people in her life didn't suspect or didn't kind of call attention to it.
it's like alcohol in that way, or no?
I mean, I think that with all substance use, there is this part of like shame and guilt, and that they're doing something wrong, and that they don't want other people to know that in some ways, if they did find out that, you know, there is a stigma attached to substance use still.
So there aren't 5 surefire signs that your wife is addicted to opioids.
Well,
there's
they're
no such thing, right?
The telltale signs.
Yeah,
Yeah.
I mean, there definitely are signs. So I think, you know, whenever you see erratic changes to someone's behavior, right? So in that instance that I just gave you, the husband didn't necessarily know that she was using drugs. There weren't like needles out on the table, or, you know, she wasn't using in front of him. But he knew something was wrong. He could tell that her personality had changed, her behavior had changed. There was this sense of secretism in the relationship that hadn't been there before. So those are signs to look for. The other things to look for is if someone is prescribed an opioid medication, that all of a sudden they're taking more of it than is prescribed, or they're trying to get refills early, or making justifications of why they need more. So that could be something that you see. And, you know, typically with substance use, there are negative consequences. And so, you know, you will see people get into trouble with the law as a result of it, or they may be stealing money from you, or, you know, just the way that sort of the interactions and the relationship change.
Right. And so what can you do about it if you're on the outside looking in at something like this that's, well, the case, something seemed wrong, but what did he do about it other than, did he talk to her about it? Or what can he do? I mean, what can family and friends do?
So I think if you notice these changes in someone that you care about, and you do suspect that there may be drug use on board, is to approach the person and have a conversation about it, and not in sort of an accusatory, shameful way, but saying, you know, I've noticed these changes in you. I've noticed the way that our relationship has changed. I'm really worried about you. I'm wondering if you might be struggling with a problem with substances, and if so, how can I help you? How can I help you get into treatment? How can I help you work on recovery? So for someone that's really stuck in that cycle of addiction, it can be really hard to talk about it with people, or kind of bring it out in the open, or ask for help. And so if you have a loved one saying, you know, I'm here to support you, you know, I'll help you find treatment, I'll help you support you through treatment, that can make a big difference.
And in her case, it probably would have, because if he would have talked to her sooner, then she ended up doing it herself.
That's when he found out, when she went to the emergency room, right?
But she went on her own. What you're saying is if he would have acted on his doubts and his questions in that sort of supportive, loving way, maybe she could have gone earlier. Is that the thought in a case like that?
Yeah, potentially, because I think part of the cycle was that she just didn't want him to find out about this. She was so ashamed of what she was doing that, you know, even going to him and saying, listen, I have a problem with heroin, I really want to get help, felt really overwhelming, and she was very worried about how he would react to it. And so I think if there had been a conversation and he said, you know, I noticed this is going on for you, let's talk about it, it sort of opens the door to have that dialogue and to get the help that you need.
But isn't it possible also that he might have said something, maybe not direct, maybe oblique, and she attacked him in a defensive way? What are you talking about? Come on, what are you picking on me? Or you're seeing things and I'm just busy at work, or
Denial.
she could have aggressively pushed him off. That might.
Sure. So we know that people are at different stages of wanting to change. And so it might be that you try to approach someone and have that conversation and offer help, and they're not at a place where they're ready to change yet.
Right.
I don't think that means you don't have the conversation, because I think every time you have the conversation, it's a chance for someone to step forward and say, you're right, I do need help, and thank you for talking about this with me.
Or at least they know people are noticing
Right.
that things have changed. Plus, I think a lot of people might not want to initiate change because they will often lose their jobs, I would imagine. You know, and that's not good. So I think there's a lot of fear in changing.
What about at work? Are there HR responses that are proper or more helpful than others?
So I think, you know, for example, we've worked with employee assistance programs, and
Right.
I think, at least from what I've heard, is their perspective is, again, it's about getting the person into treatment, that it's less about being consequential and sort of having these negative effects, but saying, okay, we've identified this problem, and now let's help you get into the treatment that will help you recover and live a different life.
Now, so there's another case where you have, there's a word in psychology you read about, enablement. How does enabling, how can friends and family make it worse? I mean, I suppose that's what enabling would be. What's that all about?
Right.
The danger of enabling.
So I think the sort of whole principle behind enabling is that, you know, as a loved one or family member of someone who's struggling with addiction, that you're doing things that sort of prevent them from experiencing those natural consequences that happen as a result of drug use. So, you know, I don't want them to feel sick, so I'm going to give them money to buy drugs, or, you know, keeping things hidden from other family members. And so sometimes enabling can make things worse because it doesn't sort of allow the person to really experience the consequences that come along with drug use. So
It seems like you're helping, but you're not.
Right.
Right.
So we try to distinguish between support and enabling, where enabling is not really addressing the problem, it's just sort of pacifying it, but that can be sort of more consequential, whereas support is really taking action, addressing the problem, and saying, how can we sort of help you get to a better place?
And when you have, I know you have families in, and friends, I suppose, in groups of sort of focus groups or help groups at your center. How often does this issue come up in those circles? Is this a common subject?
So I think, you know, the thing to recognize is that the person who struggled with addiction absolutely feels consequences, and their life is oftentimes upside down and in shambles. But the family members and friends that surround that person often have a huge impact as well. And so at our center, we really saw it important to provide education and support for the family members too, so that they could, number one, help to support the person working on recovery, but number two, get support from themselves, because oftentimes they've been laying awake worried at night, is this going to be the time that I get that phone call and my son and daughter is dead, or you know, not knowing the difference between enabling and support.
Or, and feeling strong enough to create an intervention, sometimes intervention, I guess. But, well, we'll be talking about that and more when we come back for the fourth and final segment of the Tommy Rocket Show, so please stay tuned.
Hi, I'm Alicia Silverstone with PETA. When it comes to animals, there's no need to be a classroom cut-up. Use your right to refuse to dissect frogs, cats, pigs, even worms. Contact me at PETA for information on exciting, humane alternatives to dissection. They'll help you make the grade without using animals. Remember, biology is the study of life, not death. Thanks.
Hi, and welcome back to the fourth and final segment of the Tommy Rocket Show. Peter, Dr. Langdon, as we were speaking about people in recovery and interventions, is it important for families that know there's an addict in the family to begin an intervention, or is it better to let them hit rock bottom? You know, like sometimes alcoholics, they say, save from zero. They go, how do people, what's the best?
Yeah, so I think this is sort of one of the things that's specific to opiate use disorder is that given sort of the state that we're in and the dangerous levels of fentanyl that are out there, sort of the notion of rock bottom is actually, you know, very much death a lot of the time. So
it's dangerous.
Yeah, we don't really want to wait until someone hits rock bottom because rock bottom could be death for that person. So it's much more important that if you see someone struggling or if you identify some of these signs that you're trying to intervene sooner rather than later and help them get into effective treatment like medication-assisted treatment.
May I ask you just briefly, what's the best way to create an intervention for a family member? Is there a certain way to do it?
So I think, you know, for families who have been struggling with someone with addiction for so long, the tendency or the inclination is to sort of be harsh or accusatory or tell them all the ways that, you know, they've ruined your life. But for many people who have been struggling with addiction, there's already such a high level of shame and remorse and guilt built in that just sort of makes the problem even worse. So I think to the extent that you can, really trying to approach that person with love and kindness and tell them how it has affected your relationship, right? So saying, I've noticed that since you've been going through this, you know, you've done this and you've done that, and that's affected me in this way. But I love you and I care about you and I want to see you back to the person that you were. I want to see you live a healthy life, and how can we help you get there? So really from a supportive perspective rather than being sort of harsh and critical and blaming.
Thank you.
So, and when you fail, you've lost somebody. And I'm sure that's happened. I don't know, how do you deal with that when a patient dies? How do you deal with that within your team?
Yeah, so it's something that has happened to us in our treatment center, and I think has happened to a lot of family members. And certainly there's always this feeling of like, I could have done more, I could have done something differently. You know, it is a sad reality of the epidemic that we're living in. So I think that's why it's important for family members to get support, because oftentimes they carry a lot of that blame and that guilt that goes along with it. And with treatment providers too, it's really important that we're talking about these issues and processing it and getting support from our colleagues, because it is hard to develop a connection and to have a therapeutic relationship with someone and then to see them ultimately, you know, lose their life to this addiction.
Right, and I'm sure it's tougher for the family than the staff, but it's tough for the staff, I would think.
Yeah, yeah.
Now, we talked a little bit about ending the program with some case studies. And so tell us about, of course, we're not going to name names, or tell us about some of your patients and how it's gone. Take us through a couple if you can.
So one case that I had thought about was a young gentleman who came to us who had been snorting heroin every day, 1 to 2 grams a day, and kind of got to that place where he said to us, I'm just sick and tired of feeling sick and tired all the time and hiding this from my family. You know, he had suffered a lot of consequences. He had legal involvement. He had lost his children. He had had a lot of disruption in his family, and so he was really ready and motivated to get into treatment. And we started him on Suboxone, and he was doing some of the individual therapy as well. And for the first part of treatment, he was doing really well. But we noticed about a month in that his tox screen started coming back positive for opiates again and other substances like cocaine.
Stop a second. So when you're in treatment in a case like that, you're doing blood urine tests or whatever it is, and the chemistry doesn't lie.
That's right, yeah. So tox screens are a really important part of the treatment plan because it sort of helps us know what's really going on, right? And so
and it motivates them to be good.
Yeah, I think it can be sort of a level of accountability. So people know that they're coming in every week and that they're expected to give a tox screen, and that sort of helps everyone stay on the same page and make sure that we're addressing the treatment plan. And so for this individual, he was really struggling to get back on track. You know, he continued to use opiates. In particular, he had gone back to heroin, not every day, but definitely was becoming increasingly more and more. And we had tried to increase some of the supports that were available at the center. He was working with a peer recovery coach. He was doing the therapies. But it just wasn't quite enough for this person. And so at some point in time, we kind of had a discussion with him, his treating team there, and we talked about the possibility of going into a different type of treatment. And in this case, we were thinking about referring him to methadone. And so I think his initial reaction was that, oh, you know, I've heard a lot about these methadone treatment programs. You know, he was resistant to the idea. He didn't like the idea of going every day to be dosed there. But after some kind of time and education and really helping him understand the rationale for referring him there, we ended up referring him to a methadone treatment program. And why I think this is important is that we know that treatment isn't one size fits all for everyone, that, you know, we're unique individuals and we have different backgrounds and we have different things that we're struggling with. And there are 3 FDA approved medications for opiate use disorder. And so making sure that if you're not being successful on one, that doesn't mean that recovery isn't possible. It's just maybe about getting into a different type of treatment that can better meet your needs. And so for him, I think we really needed him to know that there's other options that maybe provide more structure and support, or a different type of medication that could better meet his needs.
And do you know how that went?
We don't know how the outcome
And you never
went.
will, right?
Probably not, unless he comes back to our center. But that's, you know, the other nice thing about medication-assisted treatment is that people can move from one medication to the other. So, you know, if this individual does end up stabilizing on methadone, at some point in the future, he may choose to come back to Suboxone treatment if that fits better in with his lifestyle.
Well, that's good to know that there are options.
So you have another case.
Yes. So the other person that I had thought a lot about was a young woman who had gotten hooked on prescription pills with her boyfriend. And so...
Excuse me, recreationally, or was there an operation or an injury or something?
So in this circumstance, it was recreationally. I believe her boyfriend had been prescribed them for a period of time and then had transitioned to recreational use. And she kind of got hooked into that cycle with him. And what was interesting here is that she believed that she was taking Percocets from the street. But she...
Stop. What's a Percocet? What's the difference between an opioid and a Percocet?
A Percocet is a type of an opioid, a prescription opioid.
Okay.
So there's different kind of variations.
So OxyContin and Percocet are both...
Just different brands or
see.
types of
Okay.
opioids, yeah.
Thank you.
So she and her boyfriend were home one night and they were using pills together, and she actually overdosed at home. And fortunately, he was one of the individuals that did have a Narcan kit at home, and he administered it to her and revived her from
Saved
the
her
overdose.
life.
Saved her life, absolutely. The following day, she was actually still feeling horribly. And so she ended up going to the emergency room to be medically evaluated because she was fearful that something had happened because she was feeling so badly. So at the emergency room, they ran a talk screen and they started talking with her about treatment options. So interestingly, this is one of those cases where she thought she was taking Percocet, but that the talk screen actually came back for fentanyl. So one of the things I think is really important to kind of highlight here is that there sometimes is this misperception that pain pills are safer than, say, heroin or fentanyl. But the reality is, in today's day, there are no such things as sort of like safe pain pills, that, you know, the drug dealers have become quite crafty, and so they can actually produce counterfeit pills that look just like a Percocet that you would get from a doctor's office, but it's made out of something completely different. So in this case, it was just fentanyl. There was no other medication in it.
And there are a lot of people out there that don't know this.
Right. So she thought she was being sort of safer, using just pills, never heroin. But at the end of the day, it ended up being just a straight fentanyl pill, which is what led to her overdose. So she was evaluated in the emergency department. Our colleagues called us and said, we have this person who's here, she's in withdrawal, she's motivated for treatment, can you see her today? And so they sent her over, we talked with her about treatment options, and she was actually able to start on Suboxone that same day. And instantly, she felt significant improvement. So physically, she started feeling a lot better. She had noticed that there were all of these areas of her life that had really started to decline since she had been so stuck in this addiction.
For example, can you say something?
She talked about, at work, she would still show up to work every day, but she was sort of like going through the motions. She was barely sort of completing the tasks at work. And once she started in treatment, she sort of had this new lease on doing the job and doing the job well and wanting to sort of change that course at work.
And that's because the Suboxone blocked the effects of the residual fentanyl in her body or something? Why is that?
So I think with the Suboxone, it kept her out of that cycle of withdrawal, right? So for people that really become dependent on opioids, they have to use every single day, otherwise they start to go into withdrawal symptoms. And that withdrawal syndrome is so aversive. It's like the worst flu that you've ever had times about 100. And so that's what kind of keeps people stuck with it. And so being on Suboxone, they're no longer in that in and out, up and down cycle. So she just felt normal again.
So that worked for her, and although we're getting near the end of the program, take her forward a little bit here.
Yeah, so now her life has completely changed. She's been in treatment for several months now. She's working again. She has aspirations about going back to school. She started to change really important lifestyles, like she's going to the gym, she's
Did you get rid of the boyfriend?
Actually, her boyfriend's in treatment as well. And so it was kind of this cascade effect where she got into treatment and said, I don't think that I can do this unless you're doing it too. And so he got into treatment. And so I think it was a really positive outcome, and they're both working on recovery together.
So, so this gets us, it's a little bit of a transition, but.
It's a very happy story.
Yeah. So the epidemic that we started with, what do you, in an optimistic sort of way, what can you hope it might be like in 3 to 5 years? When you're feeling good about what you're doing and how it's going, how do you see it?
I'm hopeful. I mean, I think that they have put into place, and when I mean they, I mean the government, sort of the communities. We're really working on making changes that are important for preventing future cases of opiate use disorder, but also making treatment more accessible. And so I think that's really sort of the take-home story, is that treatment is available, it's effective, it works for people, and recovery is absolutely possible. And so it's just making sure that we get people into treatment.
Well, that's good.
Yeah, well, I mean, it's your mission is great, and thank you so much for reaching out to the populace of Rhode Island. I want to thank your center for being there. I'm sure a lot of people don't know that it exists, and hopefully by watching the show, people will know, and we'll try to have information on the screen so people can access it if they want to, because, we're here about empowering people with information to help themselves, just like you are. You're trying to empower the community with a resource to help themselves, and hopefully people will get to know that you're there and you're there to help them. And I want to thank you so much for coming. You've been very helpful, and it's awfully nice. Peter, thank you so much again.
Tommy.
The show was your idea, and thank you so much for tuning into the Tommy Rocket Show. Thank you, Dr. Langdon, again, and Peter, thank you very much, and stay tuned next time. Thank you very much for watching.
So slip inside this funky house. Whoa, dishes in the sink, the TV's in repair. Don't look at the floor, don't go up the stairs. I'm aching, I'm shaking, I'm breaking like humans do. I'm aching, I'm shaking, I'm breaking like humans do.
You hear people say it all the time. Someone else will do it. Someone else will donate blood. Because someone needs blood every 2 seconds. I'm happy to do it. It's just that it's a lot for one person to take on.
Good night. Good night.
Good night.